This presentation is mainly for theatre and recovery practitioners, ODP students, and nursing students. The aim of this presentation is to identify the complications of preeclampsia, the prompt response, fluid management, and medicine management. Let us say more about preeclampsia and eclampsia. The preeclampsia is pregnancy-induced hypertension with proteinuria plus or minus edema. Any organ system can be affected. It occurs during second half of pregnancy or immediately after the delivery of the baby. It is the major cause of maternal mortality and morbidity. And eclampsia is the occurrence of convulsions in association with the signs and symptoms of preeclampsia. 70% convulsions and pulmonary complications occur in the postpartum period in preeclampsia. Preeclampsia is very high risk to mother and baby. It can cause several complications that may lead to life-threatening conditions for mother and baby. The complications are fetal growth restrictions, preterm birth, placental abruption, HELP syndrome, eclampsia, damage to organs like liver, kidney, lungs, heart, eyes, and may cause stroke or other brain injury, cardiovascular disease. Let us see what is HELP syndrome is. HELLP. So H stands for hemolysis, that is the breakdown of blood cells. E and L stands for elevated liver enzymes, a sign of liver damage. And L and P stands for low platelet counts, leading to bleeding problems. To diagnose preeclampsia, two readings 15 minutes apart, systolic blood pressure above 160 millimeters of mercury or diastolic blood pressure above 110 millimeters of mercury or mean arterial pressure is or above 125 with or without proteinuria. Or two readings 4 hours apart, systolic blood pressure above 150 millimeters of mercury or diastolic blood pressure above 100 millimeters of mercury and proteinuria. And one of the following: headache, visual disturbance, or epigastric pain. Clonus is 3 beats or above, platelet count less than 100 times 10 square 6 per liter. Papilloedema means optical disc swelling. Clonus is involuntary muscle contraction which results uncontrollable shaking movements due to neuromuscular irritability in preeclampsia condition. Strict input and output to be monitored. Respiratory rate and oxygen saturation should be monitored to diagnose pulmonary edema and magnesium toxicity. Blood pressure and heart rate should be monitored regularly. Patellar reflex should be monitored hourly whilst on magnesium infusion. If patient has spinal anesthesia or epidural anesthesia, biceps reflex to monitor instead of patellar reflex. Invasive monitoring. RTD line should be placed for monitoring blood pressure continuously during intraoperatively and postoperatively and regular blood sampling. Central venous catheter should be placed if significant hemorrhage, oliguria, or liver tenderness. Patient with invasive monitoring must be admitted in critical care or high dependency settings. If oxygen saturation below 95%, commence oxygen therapy and consider interstitial pulmonary edema or magnesium toxicity management. Fluid management is important in preeclampsia management. Fluid restriction with total input of 80 ml per hour or 1 ml per kilo per hour, unless there are other ongoing fluid losses like hemorrhage. The total volume of 80 ml that includes intravenous fluid infusion and medications like labetalol infusion, oxytocin infusion, magnesium infusion, and oral intake. Do not use volume expansion in women with severe preeclampsia unless giving hydrolazine. Prior to or when commencing the first dose of hydrolazine, administer 500 ml intravenous crystalloid fluid infusion. Monitor urine output hourly and document on a fluid balance chart. Please note, oliguria is defined as less than 100 ml in 4 hours. Management of hypertension. Labetalol is the first choice medication for the management of hypertension in preeclampsia. Severe asthma and COPD, bradycardia, metabolic acidosis are the contraindications of labetalol. Initial therapy. If patient can tolerate tablet, give 200 mg labetalol orally. It can be repeated after 15 minutes if no initial response. If no response to oral administration or if not tolerating oral tablet, use repeat boluses of labetalol 50 mg in 10 ml over 5 minutes followed by an infusion. Can repeat bolus doses if blood pressure above 160 by 105 at 10 minutes intervals till maximum dose 200 mg. For infusion, 200 mg in 40 ml start at 8 ml per hour, double every 30 minutes until mean arterial pressure 110 to 125 reached. If labetalol is contraindicated or ineffective, hydrolazine is the next choice of medication. As I mentioned before, preload up to 500 ml Hartmann solution before or during the first dose of IV hydrolazine. For hydrolazine bolus, make 20 mg in 20 ml of normal saline, then administer 5 mg IV over 5 minutes every 20 minutes until the maximum dose of 20 mg or maternal heart rate above 120 per minute. For hydrolazine infusion, make 60 mg in 60 ml normal saline and infuse via infusion pump. Start the infusion at 2 mg per hour with increase the rate of 0.5 mg per hour every 20 minutes until mean arterial pressure 110 to 125 or to a maximum rate 18 mg per hour. The effect of hydrolazine lasts up to 6 hours. Stop the infusion if tachycardia with above 120 per minute, profound hypotension, stabilized blood pressure with mean arterial pressure less than 125, hot flush or blotchy rash. If labetalol and hydrolazine are contraindicated, the next choice of medication is nifedipine. Obstetric consultant should be involved in the decision to administer nifedipine. Please note, nifedipine 10 mg immediate release only orally, not sublingually. Nifedipine and magnesium sulfate can interact to cause profound muscle weakness, maternal hypotension, and fetal distress. Magnesium sulfate is using for the prevention and treatment of eclamptic fit. Administer magnesium sulfate if severe hypertension or severe preeclampsia has or previously had an eclamptic fit. Delivery planned within 24 hours. Severe preeclampsia with concerns, risk of eclampsia or eclamptic fit. Magnesium loading dose is 4 gram in 20 ml over 5 to 10 minutes with infusion pump. Obstetric middle grade doctor should remain with patient during the administration of loading dose. Maintenance dose is 1 gram in 5 ml per hour and continue for 24 hours after the delivery or feeds. Recurrent seizures treat with either bolus 2 to 4 gram or an increase in infusion rate to 1.5 gram or 2 gram per hour. 10% calcium gluconate is the antidote for magnesium sulfate. Check magnesium level and reduce or stop magnesium sulfate infusion if patient feels weakness, oliguria with less than 25 ml per hour or excessive drowsiness. Stop infusion and send blood for magnesium level urgently if reflexes disappear, respiration is impaired to less than 12 per minute or oliguria. The therapeutic magnesium level is 2 to 4 millimoles per liter. Increased toxicity if magnesium level is more than 4 millimole per liter. Cardiac arrest will happen if it is more than 12 millimole per liter. Contraindication to magnesium sulfate. Patient taking digoxin. Caution in a patient with signs of cerebral irritation and confusion, acute renal failure, and myasthenia gravis. Magnesium sulfate is contraindicated or fits remain uncontrolled. Diacetyls is the other choice of medication, only considered by lead consultant and anesthetist. The administration of diacetyls is 10 to 20 mg IV bolus slowly. Diacetyls may induce apnea or cardiac arrest. Management of oliguria. If total input is more than 750 ml in excess of output since delivery, 20 mg of IV furosemide should be given. If total input less than 750 ml in excess of output since delivery, infuse 250 ml Hartmann solution over 20 minutes. If after furosemide, a diuresis in excess of 250 ml occur in the next 4 hours, the fluid should be replaced with 250 ml Hartmann solution over 60 minutes in addition to baseline 80 ml per hour. The decision to administer diuretics should be by anesthetist or consultant obstetrician. Natural diuresis will occur around 36 to 48 hours post-delivery. Post-delivery or cesarean section, continue to monitor respiration and oxygen saturation, heart rate and blood pressure, monitor input and output, and patellar reflex or biceps reflex if patient had spinal or epidural anesthesia. Fluids should be continued 80 ml per hour if no evidence of pulmonary edema. Magnesium sulfate infusion should be continued for 24 hours after delivery. The decision to stop labetalol infusion or hydralazine infusion should be made by obstetric consultant or registrar. Oral antihypertensive should be commenced to control blood pressure if necessary. Exit from the protocol when patient should have normal conscious level, no fits for 24 hours, diastolic blood pressure should be less than 100 without antihypertensive, adequate urine output, proteinuria resolving, hepatic and clotting impairment resolving. Thank you for listening. Please subscribe my channel for more clinical presentations.